This is the second talk about somatosensory evoked potentials intraoperative monitoring. It is intended for the Nick Klaus Children's Hospital Fellows. This talk will be conducted in a question and answer format. The first question is, intraoperative somatosensory evoked potentials are used for A. Localizing the central sulcus, B. Monitoring induced biological changes, C. Monitoring the spinal cord during surgery, D. All of the above. Intraoperative somatosensory evoked potential has three main applications. The first one, and probably the most important one, is the prevention of neurological damage by alerting the surgeon of impending doom. This task can only be accomplished if the neurological structure that may be injured during the procedure is being surveyed, and if the neurological structure being surveyed contains enough eloquent elements to the prevailing pathology. As you know, some structures are exquisitely vulnerable to mechanical damage and rather resistant to ischemia and vice versa. The second application for intraoperative somatosensory evoked potentials is to follow up induced biological changes such as hypothermia and ischemia. And the third one is the localization of the central sulcus. So the answer to this question is D. Next question. Somatosensory is better than BERA for intraoperative survey of the brainstem. A true, B false. The choice of the type of intraoperative evoked potential monitoring more fitting for a given procedure depends on the eloquent structures present in the region at risk for the given stimulus modality. Somatosensory evoked potential eloquent brainstem elements are the cuneatus nucleus and perhaps the superior colliculi. The BERA eloquent elements are more numerous. They include the ventral and dorsal cochlear nucleus, the nucleus of the trapezoid body and probably its fibers, both lateral lemnisci, both superior olivary nuclei, both nuclei of the lateral lemniscus, the inferior colliculi, and the brachium of the inferior colliculi. So the answer to this question is false. Next question. Ulnar nerve somatosensory evoked potentials are as good as median nerve somatosensory evoked potentials for spinal cord monitoring during spinal surgery. A true, B false. This drawing is an schematic representation of the sensory homunculus. In it, I have colored the cutaneous sensory area of the median nerve in the hand and the corresponding area in the cortex. Now I have colored the ulnar nerve cutaneous sensory area in the hand and its representation in the cortex. So it would seem that the median nerve somatosensory evoked potential cortical potential should generate a more robust potential than the ulnar nerve somatosensory evoked potential. Yet this is not the case median and ulnar nerve somatosensory evoked potential produce potentials of similar magnitude. A possible explanation for this occurrence is that the median nerve receives muscle sensory fibers involved in conscious proprioception from 4 muscles, whereas the ulnar nerve receives conscious proprioception from over 20 muscles. So it may well be that were we to create a cortical homunculus for muscle sensory fibers, the smaller cortical representation of the median nerve, which I have signaled by the green stripes, and the larger cortical representation of the ulnar nerve, which I have represented by the yellow stripes, compensate for the difference in cutaneous innervation. So the answer to this question is B. Next question. Median and ulnar nerves somatosensory evoked potentials evaluate the same spinal cord segments but different brachial plexus structures. A true, B false. This frame shows all the components of the brachial plexus. This frame only shows those components of the brachial plexus that have fibers coming from the median nerve, hence tested with the median nerve somatosensory evoked potentials. We can see that the median nerve somatosensory evoked potential evaluates almost the whole plexus except for the posterior divisions and the posterior cord. Median nerve somatosensory evoked potential also tests the spinal nerves, rootlets that lead to the brachial plexus. Median nerve somatosensory evoked potential also evaluate the spinal cord from T1 and above. I have now reintroduced the whole brachial plexus so you can see the relation between the ulnar nerve and the brachial plexus. As you can see, the only brachial plexus structures that receive fibers from the ulnar nerve are the medial cord, the anterior division of the lower trunk, and the C8 and T1 rami. In addition to this structure, ulnar nerve somatosensory evoked potential also evaluates C8 and T1 spinal nerves, root and rootlets. The ulnar nerve somatosensory evoked potential, the same as the median nerve somatosensory evoked potential, evaluates the spinal cord from T1 and above. So the answer to this question is true. Next question. A patient undergoing surgery requiring a position with one arm overhead should have dash during the procedure. A. Ulnar nerve somatosensory evoked potential of the extended arm. B. Bilateral ulnar nerve somatosensory evoked potential. C. Ulnar and median nerve somatosensory evoked potentials of the extended arm. D. None of the above. The ulnar nerve is often damaged when the arm is placed in an overhead position during surgery. In this position, the armpit angle increases. The increased armpit angle places the lower brachial plexus at risk. Bilateral ulnar nerve somatosensory evoked potentials are indicated in these cases using the non-extended arm as control. So the answer to this question is B. Next question. Absence of N20 in the presence of P37 is likely to indicate a lesion close to the thalamus. A true, B false. Somatosensory evoked potentials can be used for vertical localization and for horizontal localization. But as we will see, it is far more useful for vertical localization than for horizontal localization. The sites of electrode placement for intraoperative evaluation of the upper and lower extremity somatosensory evoked potentials are different, but the waves obtained corresponds to similar or at least equivalent structures. In the median nerve stimulation or ulnar nerve stimulation, the waves analyzed are the air point potential, P1314, N18, which in this frame is being represented as being generated in the thalamus, but some authors believe it is generated at the level of the tectum, and N20. When performing posterior tibial nerve somatosensory evoked potential, the waves analyzed are the popliteal fossa potential, P31, N34, and P37. In addition, in some centers, including ours, cervical electrodes are used to capture the stationary cervical potential generated by the cervical dorsal horn cells in the case of arm somatosensory evoked potentials, and in the case of arm and leg somatosensory evoked potential, the traveling electrical volley as it ascends towards the brainstem. So the presence or absence of this potential and the appropriate or prolonged conduction between them helps to localize the lesion to the spine, the brainstem diencephalic segment, or the cortical subcortical segment. Somatosensory evoked potential can also be theoretically used for horizontal localization, but the use in this endeavor is much less rewarding. Horizontal localization can be achieved at any of the three segments, but is only partially reliable in the spine and in the brain. At the level of the spine, normal posterior tibial somatosensory evoked potential and abnormal upper extremity evoked potential suggest, at least theoretically, a cuneatus fascicle or nuclear lesion and sparing of the gracilis fascicle and nucleus. This is only so if a cortical lesion or an upper extremity peripheral nervous system lesion can be ruled out and the possibility of artifacts eliminated. On the other hand, an abnormal posterior tibial somatosensory evoked potential and a normal median nerve somatosensory evoked potential indicates, again, at least theoretically, the affectation of the gracilis fascicle and nucleus and the sparing of the cuneatus fascicle and nucleus. Once more, we must remember that this is basically theoretical consideration, and other possible localization for the damage should be considered way before we think of this option. At the level of the brain, a lesion deep in the centrum semiovale is likely to produce upper and lower extremity somatosensory evoked potential abnormalities, that is, absence of P37 and N20. Whereas a cortical lesion involving the lateral hemisphere is likely to produce an abnormality only in the upper extremity somatosensory evoked potential with normal P37, and a cortical lesion involving the mesial aspect of the hemisphere is likely to produce an abnormal lower extremity somatosensory evoked potential and a normal upper extremity somatosensory evoked potential. So the answer to this question is false. Next question. Which of the following structures tested during intraoperative median nerve somatosensory evoked potential stimulating at the wrist contributes to P1314? A. Rostral spinocerebellar tract. B. Dorsal spinocerebellar tract. C. Lateral spinothalamic tract. D. Cuneo-cerebellar intended fibers. only ascending fibers carrying information from the upper extremity will be activated by upper extremity somatosensory evoked potential. And among them, only those having a relay nucleus at the medulla are likely to contribute to P13-14. So, the anterior and lateral spinothalamic tracts do not have any relay nuclei in the brainstem and are therefore eliminated from contributing to P13-14. The rostral spinocerebellar tract and the spinotectal tract do not have any connecting nuclei at the level of the medulla, therefore they do not contribute to P13-14. So, at least theoretically, only 3 tracts may contribute to P13-14. Those tracts are the cuneatus fascicle, the spinothalamic tract, and the spinoreticular tract. The cuneatus fascicle carries conscious proprioception and epicritic sensation to the cuneatus nucleus. And it also carries unconscious proprioception to the accessory cuneatus nucleus. The spino-olivary tract carries unconscious proprioception to the inferior olivary nucleus. And the third possible contributor to P13-14 is the spinoreticular tract. This is based on the fact that there are reticular nuclei in the medulla. Yet, although possible, it is unlikely that this tract contributes to the generation of P13-14 because the fibers in the peripheral nerves bringing information to the spinoreticular tract are thinly myelinated or unmyelinated, and therefore have a very high stimulation threshold, a threshold that is usually not reached during somatosensory evoked potential intended stimulations. So the answer to this question is D. Next question. Which of the following structures is likely to be tested during intraoperative median nerve somatosensory evoked potential with stimulation at the wrist using a C5 electrode? A. Rostral spinocerebellar tract. B. Dorsal spinocerebellar tract. C. Lateral spinocerebellar tract. D. Cuneocerebellar intended fibers. An electrode at the level of C5 is often used for spinal nerve monitoring. This electrode is usually referred to FC. As you can see in this frame, from a left somatosensory evoked potential and the right upper extremity somatosensory evoked potential, theoretically, 2 types of field may contribute to the C5 potential. A traveling field resulting from the electrical volley traveling in the ascending tracts, and a stationary field resulting from the activation of dorsal horn cells as collateral axons make contact with these cells in the cervical spine. This figure shows the 4 structures mentioned in this question. The rostral spinocerebellar tract, which I will show you in the next frame, is activated by median nerve stimulation. Here I have represented the rostral spinocerebellar tract in red. This tract starts in the dorsal horn of the cervical spine, likely as low as C8 and T1 segments. It travels ipsilaterally in the cervical spine to reach the cerebellum without making any connections in the brainstem. Thus, although not contributing to P13-14, the rostral spinocerebellar tract may contribute as a conduit for electrical traveling volley to a cervical potential. Another tract that can possibly be a contributor to a cervical potential following median nerve stimulation is that formed by the fibers destined for the accessory cuneatus nucleus. These fibers, after entering the dorsal spine from as low as C8 and T1 segments, travel in the cuneatus column to reach the accessory cuneatus nucleus. In this figure, I have drawn these fibers that carry unconscious proprioception signals, going from the dorsal ganglia to join the posterior column, then to reach the accessory cuneatus nucleus. It is the action of those neurons in the accessory cuneatus nucleus that form the cuneo-cerebellar tract. The lateral spinothalamic tract, although unlikely to be a significant contributor to a cervical recorded potential, may do so since it carries information from the median nerve territory through the cervical spine towards the thalamus. Again, its contribution would be limited to the traveling field produced by the electrical volley. The dorsal spinocerebellar tract is not activated by median nerve stimulation since it carries fiber from the lower extremities. So, the C5 potential is generated by an stationary field created by activation of the dorsal horn cells by fibers ascending in the cuneatus fascicle, and the fields created by the ascending electrical volleys in multiple tracts activated by median nerve stimulation. So the answer to this question is B. Next question. The cuneo-cerebellar fibers enter the cerebellum through the inferior peduncle. A true, B false. I hope you recognize this chart. As you can see, it has a blank space below posterior spinocerebellar tract. That space is for the cuneo-cerebellar tract. This tract carries information from muscle spindle and joint receptors. It does not decussate. It carries information from the upper extremities, as we have just heard. It originates in the accessory cuneatus nucleus. It enters the cerebellum through the inferior peduncle and ends at the cerebellum fastidial nucleus, at the interpost cerebellar nucleus, and at the cerebellar cortex. So the answer to this question is true. Next question. Typically, a -% drop in amplitude and a -% prolongation in latency is considered significant. A 50 and 50, B 10 and 50, C 10 and 10, D 10 and 10. Always warn the surgeon when stability is lost, because any change in stability of a potential can be an indication of significant damage, and only the surgeon knows what he's doing at the time. But typically, the word significant, implying significant pathology, is present when the amplitude drops to 50% or more. Another criteria for significant is when the prolongation in latency is more than 10%. So the answer to this question is C. Next question. Posterior tibial nerve stimulation at the ankle produces higher cortical potentials than common peroneal nerve when stimulated at the popliteal fossa. A true, B false. Despite the common peroneal nerve being a thicker nerve at the popliteal fossa than the posterior tibial nerve at the ankle, the cortical potential generated by stimulation of the posterior tibial nerve at the ankle has a higher amplitude than the cortical potential generated by stimulation of the peroneal nerve at the popliteal fossa. So the answer to this question is A. Next question. During a surgical operation, the disappearance of N20 within 2 minutes of clamping the medial cerebral artery is a bad sign. A true, B false. One of the applications of intraoperative monitoring is following induced biological changes. One of these biological changes is ischemia. Surgeries that require medial cerebral artery clamping or surgery of the aorta are likely to produce cerebral ischemia. The degree and duration of the ischemia needs to be monitored to prevent neurological damage. When the median cerebral artery territory in the brain is rendered ischemic by a surgical procedure, the likelihood of brain damage can be foreseen by taking into account the speed of N20 disappearance and the duration of this disappearance. This chart relates the amplitude of N20 in percent and times in minutes. So N20 amplitude is a good marker for brain circulation in the middle cerebral artery territory. If we consider the pre-arterial manipulation N20 amplitude to be 100% and follow the drop in amplitude until it disappears, the likelihood of permanent brain damage can be predicted. Animal studies have shown that when circulation drops to less than 15 to 18 milliliters per 100 grams of brain tissue per minute, the brain hurts. And if it is sustained, permanent brain damage will occur. It has also been determined that when circulation drops to about 15 to 18 milliliters per 100 grams of brain tissue per minute, N20 disappears. These facts have brought about the concept of N20 disappearance time of tolerance, which takes into account the time after clamping that it takes for N20 to disappear and the duration of this disappearance. The reasoning behind using the speed of disappearance as a criteria is experimental. It is based on a third fact. This fact is that the fewer collateral irrigating an area of the brain, the less time it takes for that area to stop generating a potential. So, when it takes more than 4 minutes for N20 to disappear after clamping the medial cerebral artery, the maximal tolerance time is 20 minutes. This implies that if it goes longer for 20 minutes, there will be certainty of brain damage. If N20 disappears in about 4 minutes, the maximal tolerance time is 10 minutes. If N20 disappears within 2 minutes, there is no tolerance time. Permanent brain damage is likely to occur soon after, unless clamping is released immediately. So the answer to this question is A. Next question. Which of the following statement is not true regarding EEG and carotid endarterectomy? A. A drop in amplitude of less than 60% may not be significant. B. The fast EEG drug-induced activity is more resilient to ischemia than cortical activity. C. The sensitivity of EEG during carotid endarterectomy should be set at 2 to 3 microvolts per millimeter. D. Significant EEG changes for 6 to 10 minutes is usually linked to permanent brain damage. In addition to monitoring N20, monitoring EEG activity using regular EEG filtering but with sensitivity of 2 to 3 microvolts per millimeter after anesthesia is also used to monitor brain oxygenation. For this purpose, a good rule to remember is the 10-20 rule. Most brains do not end up injured in the presence of 60% drop in amplitude of the EEG activity for a relatively long period of time. A drop in amplitude of more than 60%, if persists beyond 6 to 10 minutes, is likely to be associated with postsurgical neurological deficit. Fast activity resulting from drug use during anesthesia is more sensitive than regular EEG activity to ischemia. Thus, this activity, when present, should be monitored, and a drop below 60% be considered significant even when it is not associated with a drop in regular EEG activity. So the answer to this question is D. Next question. Recording somatosensory evoked potential from cortical surface of the brain requires dash repetitions. A. 25 to 50. B. 250 to 1000. C. 5 to 10. B. 50 to 100. A scalp recorded potential is done using regular EEG electrodes. It usually takes about 250 to 1000 repetitions, but if you have a good signal to noise ratio, fewer repetitions will do. Somatosensory evoked potential recorded from the cortical surface requires spatial platinum electrodes. Reproducible potentials can be obtained when 25 to 50 repetitions are used because cortical recorded somatosensory potential tend to be higher, in the range of 200 to 500 microvolts. Despite this, for cortical as well as for scalp recorded potentials, 2 superimposed trials are recommended to check stability of the recording. So the answer to this question is A. Next question. Spinal potential can be recorded with dash electrodes. A. Esophageal. B. Scalp. C. Needle. D. All of the above. Spinal potentials can be recorded using a surface electrode in the back and another one in the front of the neck. Needle electrodes inserted in between the spinous process or over the lamina of the spine column can also be used to record a spinal cord activity. As esophageal electrodes can be used. Also, with the scalp recording, we also get far potentials from the spine. Therefore, they are also appropriate for a spinal recording, but only of those far field potentials. So the answer to this question is D. Next question. All agree that central sulcus determination is based on a dipole-oriented perpendicular in the central sulcus. A true, B false. As you would expect, some say yes, some say no. Those that say no argue that what we are seeing is the N20 sensory area generated potential and the P22 motor area generated potential. So the answer to this question is false. Next question. What is the minimum number of electrodes for central sulcus localization? A8, B16, C24, B32. The minimum number of electrodes to be used when searching for the central sulcus is 16. The strips are placed from the anterior to posterior as shown in this picture. The strip should be placed perpendicular to what is believed to be the central sulcus. These electrodes should be referred to the contralateral mastoid. This is a picture of the position of the electrodes in the actual brain. Remember that the electrode should be of platinum, since otherwise there may be a reaction with the brain that may injure the brain. So the answer to this question is B. Next question. The potential with the highest amplitude is present at A. Central sulcus, B. Cortical hand region, C. Cortical mouth region, D. None of the above. A clue to the location of the central sulcus is that the sensory hand region has the highest potential. The sulcus is usually in front of the electrode with the highest amplitude potential. It is important thus to adjust the amplitude rejection window of the scoring system so high amplitude potentials are not rejected. So the answer to this question is B. Next question. Cortical referential montages allow sulcus localization by phase reversal. A true, B false. For simplicity, I will only show one strip in this frame. In this new frame, I have introduced a montage with each electrode in the strip being referred to the right ear. An apparent phase reversal is present if we disregard the small difference in peak latencies of the two waves between the tracing obtained by the second and the third derivation. Notice that the larger negative potentials is present in the third derivation and in the fourth derivation. Also notice that the derivation number 2 shows a positive potential. So the answer to this question is A. Next question. Cortical bipolar montages allow sulcus localization mainly by localizing the hand region. A true, B false. This is a referential recording that established the presence of the central sulcus between the 5th and the 6th derivation. The apparent phase reversal occurs between 5 and 6, as you can see indicated by the green arrow. The highest negative potential is present in the 6th derivation. So the highest potential is likely to be there. This can be confirmed by the phase reversal in the bipolar montage. Remember that phase reversal found in bipolar montages are often referred as false phase reversal, since what they indicate is the highest amplitude of the field and not the presence of a dipole. So, as we previously mentioned, a clue to the location of the central sulcus is that the hand region has the highest potentials. The sulcus is usually in front of the electrode with the potential with the highest amplitude. So the answer to this question is A. Next question. Look at this montage and choose how was the strip placed. If you look at a brain and you see three sulci that you can potentially consider to be the central sulcus, and then you look at the accompanying tracing and you see an inverse phase reversal, you have found the central sulcus between the phase reversing electrodes, in this case between the fourth and the fifth derivations. But there is a problem. The problem is that the frontal derivation, in this case the fourth derivation, has a negative potential, and the neighboring posterior derivation, that is in this case the fifth derivation, has a positive potential. In the presence of this polarity arrangement, you have to postulate that the positive field is generated in the sensory area and the negative field is generated in the frontal area, which is an anatomical impossibility. Or that the strip was inadvertently placed backwards, which was the case. So, to locate the central sulcus, find the phase reversal in the referential montage. Make sure the positivity is in front of the negativity. And make sure that the negative potential has the biggest amplitude. So the answer to this question is B. Next question. You are trying to localize the central sulcus and you have this tracing. What would you do? A. Increase stimulus duration. B. Increase stimulus intensity. C. Move the strip. D. All of the above. This montage does not show a clear phase reversal. It could be argued that the phase reversal is taking place between derivation 5 and 6 or between derivations 6 and 7. The highest potential, another criteria used to find the central sulcus, is at the end of the chain, raising the possibility that an even higher potential could be present after the 8th electrode. The only clear criteria in this montage that is met for the selection of the central sulcus is that the negative potentials are in the posterior derivations. In the presence of such confusing picture, the best approach is to move the strip in the direction of the tallest potential, as I have done in this montage. Now the location of the central sulcus can be determined with precision by noticing the phase reversal between the fourth and the fifth derivations. So the answer to this question is C. Next question. Median nerve somatosensory evoked potential P30 involve the prefrontal cortex. A true, B false. P30 is a parietal generated potential. It may correspond to the parietal lobe association area. So the answer to this question is B. Common peroneal somatosensory evoked potential may be preferable to posterior tibial nerve somatosensory evoked potentials in patients with A. Undergoing surgery that places L2 level at risk, B. Multiple sclerosis, C. Neuropathy, D. All of the above. Lower extremity somatosensory evoked potential are used when the spinal cord below the C8 level is at risk. Posterior tibial nerve somatosensory evoked potential is preferable to common peroneal somatosensory evoked potential, except in patients with distance-dependent neuropathy or amputees. So the answer to this question is C. Next question. In which of the following scalp locations you may find P37 during posterior tibial nerve somatosensory evoked potentials? A. CPI, B. ZD, C. BZ, D. All of the above. Using the regular montage, the usual place to find an isolated P37 is the centroparietal region ipsilateral to the stimulus. This location should be referred to the contralateral centroparietal region in order to get the isolated P37. Yet at times, isolated P37 is found in the midline centroparietal region, referred to the contralateral parietal region. P37 with P31 and N34 can also be found using CPI or CPZ if referred to a neutral point such as EPC, that is air point potential, contralateral to the stimulus. And the last derivation usually used with posterior tibial nerve somatosensory evoked potential is the one going from the ipsilateral popliteal fossa, that is ipsilateral to the stimulation, to the contralateral posterior fossa, or referring the popliteal fossa ipsilateral electrode to the contralateral air point. The first of these two possibilities usually gives you better recording. So, since at the beginning of a study the location of P37 is unknown, some authors recommend that different locations be surveyed prior to selecting the site for the placement of the cortical electrodes. The place to start is using the centroparietal region ipsilateral to the stimulus, followed by the centroparietal region midline, followed by the contralateral centroparietal region, then the midline central region, followed by the midline parietal region, and the last site to be evaluated is FPC. FPC is often a good electrode because it can be used as a reference since it usually does not record P37. The electrodes I just mentioned can be referred to the contralateral air point to analyze the wave they produce. So the answer to this question is D. Next question. In the presence of a preserved EP potential, P13-14, N18, popliteal fossa potential, P31 and N34, and the loss of N20 and P30, where would the lesion be? A. Thoracolumbar spinal cord. B. Cervical spinal cord. C. Brainstem above the lower medulla and below the thalamus. D. Cortical mantle and subcortical white matter. Damage in the spinal cord below C8 or T1, shown in here as a red area inside the spinal cord, is characterized by preservation of all ulnar potential and, in the lower extremity, preservation of the popliteal fossa potential. All other leg potentials are absent or greatly diminished. Cervical spine injury is characterized by the presence of air point potential and the absence or significant decrease in amplitude of all other ulnar nerve potentials. Lower extremity somatosensory evoked potential will show a popliteal fossa potential to be present, and all other potential from the lower extremity somatosensory evoked potential will be absence or significantly decrease. If in this case the lumbar potential is being recorded, this potential will be present. A lesion in the brainstem diencephalic region will produce preservation of the potentials from the air point and P13-14 in the upper extremities, and preservation of popliteal fossa and P31 in the posterior tibial nerve somatosensory evoked potential. All other potential will be absent or greatly diminished. Lesions in the cerebral hemisphere extending from the thalamus to the cortex will produce absence of N20 and P37 with preservation of all other waves. N20 and P37 do not have to be completely absent. They can be greatly reduced, and this will also imply a significant abnormality. The same will occur with a pure cortical lesion involving the lateral and the mesial surface of the contralateral hemisphere. Theoretically, a cortical lesion in the distribution of the middle cerebral artery leads to absence or significant decrement of N20, but would spare all other waves, including cortical P37. A lesion producing cortical damage in the territory of the anterior cerebral artery will lead to absence of P37 with preservation of all other waves. Brachial plexus lesion will affect all upper extremity potentials and spare all lower extremity potentials. A lesion in the lumbosacral plexus will produce the opposite pattern, except that the popliteal fossa potential will be present. So the answer to this question is D. Next question. Popliteal fossa potential can be recorded using needle electrodes. A true, B false. A needle electrode in the popliteal fossa, referred to a subcutaneous electrode in the gluteal region, can be a very useful method to record posterior tibial nerve somatosensory evoked potential in the popliteal fossa with minimal artifact. the proximity of the referential electrode to the searching electrode decreases the amount of artifact. So the answer to this question is A. Next question. A kill-end effect refers to the appearance of a high amplitude negative wave immediately rostral to a spinal lesion producing a complete conduction block. A true, B false. The MRI in this figure shows a block starting at T1, T2 and ending at about C8. After epidural stimulation at the level of L2, in the first derivation from T3 to T4, you can see a brief and low amplitude initial positive potential followed by a large negative potential that drowns the subsequent positive potential. This finding corresponds to the traveling healthy quadrupole. The following derivation recorded from T2 to T3 records a similar configuration, again reflecting a healthy quadrupole. The T1 to T2 derivation recording from the damaged area of the spine shows strong positive wave followed by a minute negative wave and an equally puny second positive wave. The explanation for this pattern is that at this point only the positive field of the trailing dipole is capable of generating a healthy potential, since the rest of the quadrupole is already in the damaged area. In this frame, I have placed the quadrupole in the spine to make it clearer. It is important to stress that this explanation has many holes, but it is a good way to remember what actually happens. In this new frame, I have just placed on top of the tracing the quadrupole to make it more visual by establishing a relation with the wave. Notice that the positive wave corresponds to the positive field of the trailing dipole. The small negativity in front of the positive wave corresponds to the posterior negative field created by the leading dipole and the anterior negative field of the trailing dipole. The most anterior positivity corresponds to the positive field of the leading dipole. Rostral to the complete block, we only see a positive wave, which it is believed to be a positive far field which occurs in the segment above where only the positive wave is present. Again, believed by most to be a positive far field. All in all, the findings associated to a complete spinal block consist of the loss of the negative wave at the point of the block, the appearance of a positive wave at the point of the block, and the presence of a positive wave rostral to the block. So the answer to this question is false. Thank you very much for your attention.